Hey there, everybody. This is Dr. Parsons coming at you from the comfort of my office. Hope you guys are all staying well. So I'm thinking that I'm going to try to maybe put out some of these little webinars, I guess, for lack of a better term. Just kind of a quick primer on some of the different, more common pediatric tumors that we encounter in pediatric practice. Hopefully to kind of supplement the ongoing sign-outs that you guys are doing, and maybe give you a little bit of boards prep. So today, I think what we're gonna first focus in on is pediatric renal tumors. This will just be kind of a broad overview. Definitely don't wanna try to overwhelm you guys with this stuff. So we're gonna start by talking about Wilms tumor, because Wilms tumor is the most common primary renal tumor that occurs in children. It's probably the second most common solid extracranial tumor in kids. And as you probably just noticed, if you put enough modifiers in front of anything, you can make it the most common of all things. So, Wilms tumor, like many pediatric tumors, is a primitive neoplasm that's derived from some sort of primitive precursor cell. In this case, it's derived from immature blastema, essentially. And the tumor itself is really kind of trying to recapitulate development of the normal kidney, but it's gone like totally awry. So I'm gonna throw the slide up here. If you give me a sec to get in focus on the screen. So a couple things about Wilms tumors. Number one, when you first start to look at a Wilms tumor, one of the things that you'll probably notice, hopefully here on low power, is we've got some normal kidney that's out here on the right-hand side. And then we've got some stuff that's clearly not normal kidney. And it's separated from each other, or they're separated from each other by this sort of almost fibrous pseudo-capsule, if you will. We're gonna get a little bit higher just so that you guys can see, hopefully, the really clear demarcation of tumor from normal kidney with this fibrous capsule in the middle. And so this fibrous capsule can be really helpful in cases where it's not super clear right away that it's a Wilms tumor, because Wilms tumors are virtually always encapsulated like this, at least in some spot. So if you look now at the tumor itself, you'll be able to hopefully appreciate that this tumor has a couple different appearances. So there are different components to this tumor. You'll notice that there are these little circular things kind of scattered throughout. Maybe even this guy that really wants to be a glomerulus and is just not quite making it. Same with these guys. So these components here that look like tubules and glomeruli are what we refer to as the epithelial component of the Wilms tumor. So here's a look at some of those on higher power. Hopefully you can appreciate this. Almost looks like a little immature glomerulus. This looks like a little renal tubule, maybe a baby renal tubule. This is the epithelial component. And it is super helpful if you're looking at a pediatric kidney tumor and you can find these epithelial elements. No other pediatric renal tumor is going to have epithelial elements like this. And so once you find these, you can feel really confident that you're dealing with a Wilms tumor. Another component that we see in these tumors is what's called the blastemal component. And that's this background sort of sheet-like distribution of undifferentiated looking cells. This is the blastemal component. It's kind of nondescript and hard to differentiate from other small round blue cell tumors. So you can imagine that if this makes up the majority of the tumor or the entirety of the tumor, it can be kind of difficult to differentiate it from other pediatric small round blue cell tumors. The final component that we tend to see in these tumors is the so-called stromal component, which is depicted here in the middle. And so the stromal component is basically kind of immature fibrous tissue, but it can turn into pretty much anything. So we will see fairly frequently stromal component that shows some skeletal muscle differentiation. This doesn't really have any significance clinically, but it's just kind of a fun thing that we can find. And you can find other types of stromal differentiation in a Wilms tumor. So those are the three components, and that's what we mean when we say triphasic Wilms tumors. Now, we sometimes talk about certain tumors being epithelial predominant or blastema predominant. And that means that that particular component comprises greater than 2/3 of that tumor. At this point, doesn't have a ton of prognostic significance, but it's something that we're kind of keeping track of as we continue to study these tumors. So this is what a very classic triphasic Wilms tumor looks like. It has all three different components within it: the epithelial component, the blastemal component, and the stromal component. And it's separated from the rest of the kidney by this nice fibrous pseudocapsule, which we can kind of see out here again as well, separating the normal kidney from the tumor kidney. So, like I said, it can be at times a little bit challenging if you have a tumor that's composed completely of blastema. And so this tumor is an example of that. This is a so-called blastema predominant Wilms tumor. And gosh, it's really kind of tough to make out whether there's any epithelial elements or not. So maybe over here, we might be getting a little bit of epithelial differentiation, almost kind of rosetting. So in situations like this, where the tumor, where it becomes difficult to figure out whether it's a blastema predominant Wilms, although here's a nice little rosetta form epithelial structure over here. If you can't figure out you can always do a PAX8. So PAX8 is a kidney marker, among other things, and it can be really, really helpful in trying to confirm that you're dealing with a Wilms tumor in a situation where you can't find blastema or any epithelial component. So sometimes it does just look like sheets and sheets of small round blue cells, and those can be a little bit trickier. But like I said, PAX8 can be helpful. WT1, it stands for Wilms tumor, but it's not necessarily all that helpful. It can be a really difficult immunostain to kind of optimize, and you have to have nuclear staining in order to interpret it as positive. I'm not a huge fan of it, but just so that you're aware, if you do stain it like that, you're looking for nuclear positivity with WT1. Now, with respect to the histology of these tumors, one of the things that we as pathologists are responsible for is figuring out whether these tumors are favorable histology or unfavorable histology. Now, unfavorable histology tumors are tumors that have what we call anaplasia, nuclear anaplasia. So how do we define that? So anaplasia is defined by nuclear size being greater. An anaplastic cell is a cell that has a nucleus that is hyperchromatic and 3 times larger than its neighbors. And you also have to have abnormal polyploid multipolar mitotic figures as well. So here in the middle of the stage, we've got a very abnormal looking mitotic figure that's multipolar. The cell itself is enlarged. This is an example of meeting the abnormal mitotic figure criteria for unfavorable histology. Things like this begin to catch your eye that are very hyperchromatic and somewhat irregularly shaped and large. And when we get out kind of to the edge of the tumor here, we can sort of begin to appreciate as well that there's some very large hyperchromatic cells out here. Now, in order for us to be able to make the designation of anaplasia, we really do have to see both these markedly enlarged and hyperchromatic nuclei, so greater than 3 times the size of their neighbors, or at least their non-anaplastic neighbors, I should say, along with those multipolar, polyploid, abnormal mitotic figures. Both must be present in order to be able to call something anaplastic. And anaplasia means unfavorable histology. And the importance of that designation is that unfavorable histology Wilms tumors, those that have anaplasia, do not respond well to conventional chemotherapies. So they get put on different chemo regimens. And they actually, overall, for low stage anaplastic tumors, they do pretty well. It's the high stage anaplastic tumors that don't respond to therapy that do not do very well. So this is an important part of your job as a pathologist, to identify those areas of anaplasia. So again, just kind of cruising around so that you guys can see, this is another abnormal mitotic figure here. Now, if we were to only have the enlargement, that would be called severe nuclear unrest. Ooh, look at that ugly guy. And that doesn't mean anaplasia, but it's important to notice, because if you find it, it might mean that there is real anaplasia. So lots of these abnormal mitotic figures, and we've seen that hyperchromasia and enlargement that we need. So this would be considered to be an anaplastic Wilms tumor. Now, anaplasia can be defined as focal or diffuse, and sometimes it gets a little murky. Technically, we define focal anaplasia as being anaplasia confined to a well-circumscribed focus or a few small foci. So yeah, that's not my favorite definition in the world. To be called diffuse anaplasia, you either have to have anaplasia everywhere, you have anaplasia present in a metastatic lesion, so in a lymph node or in a lung biopsy, or you have anaplasia in a biopsy. Now, here in the States, our protocols that we follow for Wilms tumor really rely on primary resection of the tumor before chemotherapy, because there is a significant subset of these tumors that we can get out completely with a nephrectomy, and the kids may not require therapy. So they might be done after that. Now, with the way that we stage our tumors here in the United States, biopsy is really discouraged because it upstages. We'll talk about that in just a sec. If you have anaplasia in a biopsy, though, because sometimes these tumors cannot be safely primarily resected, whether the child is really ill, whether they have bilateral tumors, whether the tumor is really large and just going to be super difficult to remove, sometimes those patients are going to get chemotherapy up front before they get their resection. So if you see anaplasia in a small biopsy, you have to assume that it represents more widespread or diffuse anaplasia. So those are kind of the criteria for favorable and unfavorable and some of the definitions that surround anaplasia. We'll talk just for a couple minutes now, I think, about the staging of Wilms tumors, because I think that that's something that's important. I'm gonna share something else with you now, so hopefully you can see this, and I'm a little nervous about putting it in presentation mode, but so I might just leave it like this. So this is an example of what a nephrectomy specimen from a Wilms tumor patient might look like. Here's the ureter over here. You can see that this really distorts the shape of the kidney. It's really hard to tell what's kidney and what's tumor. This is a cut surface section of the kidney. And so you can see that really the majority of the specimen is comprised by tumor. There is this little rim of normal kidney out here at the periphery. And sometimes you'll hear radiologists talk about what's called the claw sign. You know, it's almost like this little piece of kidney looks like a claw on top of the tumor. And they can see that by radiology. So that is something that is really supportive of Wilms tumor. So I'm going to talk just a little bit about the staging. and how both gross and histologic findings can relate to that. So a stage 1 tumor is a tumor that is limited to the kidney and is completely taken out at the time of surgery. Those patients sometimes will get followed, sometimes they will require some therapy, but they're completely resected, and no tumor is left behind, no tumor gets outside of the kidney. For local stage 2, the tumor has now gotten kind of out of the bag, if you will. It's not confined to the kidney anymore, but it has been completely resected. There are no positive margins, and all the lymph nodes are negative. So things that we can see under the microscope, and usually a stage 2 designation is a microscopic finding. Tumor that is extending through the renal capsule, so super important. Never, never, never strip a renal capsule in a pediatric renal tumor because it's important for staging. If you have involvement of the renal sinus, either the tissue, the soft tissue that's in there, or within the lymphovascular spaces that are present in that renal sinus. If you have tumor in the renal vein, but it's not at the margin, that's also considered to be stage 2. And like I said, if it involves the renal sinus soft tissue, so-called more than minimally, again, not an awesome definition, but so those are stage 2 tumors. Now, stage 3 tumors, essentially you can kind of think of it as any situation where there's tumor left in the body. So you have a positive margin, you have rupture of the tumor at the time of surgery, or you have spillage of tumor during the surgery. If the tumor gets removed in multiple pieces, if the tumor is previously biopsied, or if you find tumor in lymph nodes. Now, this is actually a really important designation because in the United States, for our protocols, when you go from stage 2 to 3, if you are diagnosed as being a stage 3 Wilms tumor, you will get abdominal radiation therapy. And so that's an important thing to identify and to be correct about. So you don't want to misinterpret, for example, a margin from the renal vein. If there's tumor in there, and then after fixation, that renal vein has kind of grossly retracted and now the tumor's sticking out, you don't want to call that stage 3 because it's not really stage 3. It wasn't really at the margin when it came out. So that's just an example of what can happen and why it's important to designate the stage appropriately, because stage 3 is kind of a big deal. Stage 4, not surprisingly, is metastatic disease. So that's disease that now has gotten outside of the abdomen. So most frequently we tend to see metastases in the lung and at times in the liver as well. And kidney tumors are weird in kids because we have stage 5 Wilms tumors. So stage 5 just means that both of the kidneys are involved by tumors at the time of diagnosis. Now you have to individually stage each of those kidneys when you are evaluating them. So it would be clinical stage 5 and then local stage 1, 2, or 3, or 4. You can run into these situations in some syndromic scenarios. So like Beckwith-Wiedemann is a good example of cases where you may end up with a patient who has bilateral renal tumors. But some of the other overgrowth syndromes, things like Denny's-Drash, and other types of underlying syndromes can be associated with bilateral tumors. So just to summarize, that's Wilms tumor. Usually it's got 3 different components, and if you can find an epithelial component, you can feel really good that you're dealing with a Wilms tumor. If you can't, PAX8 positivity can be very helpful. Make sure that you carefully evaluate the renal capsule and the renal sinus, both grossly and histologically, because that's really important to kidney tumors in kids. Remember that stage 3 disease means that there's tumor that's left behind in the body, and therefore that patient is going to end up getting more aggressive therapy. And you always want to make sure that you're looking very carefully for anaplasia in these tumors, because it's going to mean a different chemotherapy regimen for those kids. So even though their outcome isn't necessarily going to be any worse, they do require more intensive chemotherapy because those tumors aren't as responsive. So I hope that you have found this helpful, and I look forward to hopefully sharing some more of these sessions with you guys soon. Everybody take care, stay well, be safe.